tuberculosis you see. It is not just HIV which increases your risk factor to develop tuberculosis. Many other diseases have been factor of developing, increasing the risk factor of developing abdominal tuberculosis. These include our common Sati cirrhosis. Then renal failure, individuals who are on peritoneal dialysis, diabetes mellitus, underlying malignancy with chemotherapy, systemic corticosteroids. Then a very important new addition to this increasing IBD and usage of TNF alpha inhibitors of obstruction, perforation and malabsorption. Now, when I say perforation in peptic ulcer is more or less out now, and the clue for even in an acute presentation that this might be a tubercular perforation would be an X-ray and past history of subacute intestinal obstruction, unlike typhoid, which would be totally acute. Malabsorption is again a common finding, especially in chronic present would have clinical evidence of malabsorption. When we talk about predominant colonic tuberculosis, tuberculosis of the left side of colon, pain is the predominant symptom. You don't have that kind of diarrhea because in large bowel, the left-sided bowel, the diarrhea, if at all, it would be a colonic diarrhea, and hematochezia would be seen in around 1/3. But tuberculosis rarely presents. It's not common for tuberculosis to present with a large GI bleed. Bleed, if present, would be minor, and overall TB only accounts for 4% of lower GI bleeding. Other features, constitutional symptoms may still be present. For rectal and anal tuberculosis, it is considered as an important cause of anal fistula. At least was considered as an important cause of anal fistula in India. And in a series where they were evaluating for cause of, this series was from 80s, cause of fistula. In individuals who had multiple fistula, tuberculosis was much more common. 12 out of 15 patients with multiple fistula had tuberculosis, while only 4 out of 61 single fistulas were COX. So multiple anal fistula is not all, it can also be COX. In older series, it could be COX altogether. Presently, we would talk about Crohn's also on this. Rectal stricture could be a presentation of uncommonly rectal and anal tuberculosis. Hematochezia would be the most common symptom of rectal tuberculosis with constitutional symptoms and constipation. Tuberculosis of esophagus, it is rare and it's usually by extension from adjacent lymph nodes. Dysphagia or dinophagia and low-grade fever would be seen. And endoscopy, it is easier to diagnose. On endoscopy, you will find a midesophageal ulcer, which would mimic a esophageal cancer. Most of the time, a biopsy would also reveal a granuloma. A CT might help you at this diagnosis, and is usually not a difficult diagnosis. Gastroduodenal tuberculosis, stomach and duodenum each contribute to around only 1% of total cases. It mimics peptic ulcer disease. Relatively shorter history, and the patient would not respond to PPI. Can mimic gastric cancer because it would be a non-healing ulcer, and many times it is usually missed at initial presentation. The patient may have in follow-up or at presentation duodenal obstruction because of extrinsic compression from tuberculous lymph nodes. Hematosis, perforation, fistula, and obstructive jaundice are all complications which you can have gastroduodenal tuberculosis. It might be difficult to make this diagnosis straightforward. You have to be aware of this. I'll suggest the postgraduates to be aware of these three papers from India, starting from Bhansali, American Journal of Gastroenterology, 1977. He described around 300 cases, and many of the things which I've spoken here are from that paper. There are two other good reviews from Dr. V. Kapoor, Sanjay Gandhi Institute, Postgraduate Medical Journal, 1998, and MP. They describe the epidemiology of tuberculosis, abdominal tuberculosis in India in quite comprehensive way. Now, going forward, diagnosis. Well, Fossian in 1964 said for diagnosing tuberculosis, you should have a histological evidence of tubercles with caseation necrosis, a good typical gross description of operative findings with biopsy of mesenteric node showing histological evidence of tuberculosis, culture of suspected tissue resulting in growth of M. tuberculosis, and histological demonstration of acid-fast bacilli lesion. And as most of us would agree here, this is usually feasible. And diagnosis is more by clinical suspicion, which is substantiated by adequate radiological and histopathological studies. This is what Leinfelser criteria for diagnosis came up This was in late 80s and early 90s. This is more or less what we follow around the world. The clinical manifestation should be suggestive of tuberculosis. There should be imaging evidence indicative of abdominal tuberculosis, histopathological or microbiological evidence of tuberculosis, and or the last line, the therapeutic response to treatment. You should so based on these, you can characterize a patient as possible as abdominal tuberculosis. In most of these research, Langenfelser criteria, uh, with the refined language, it is microbiological positivity. It can be a AFB positive, it can be a AFB culture positive, or it can be what we call commonly known as gene negative, talking about positive. Then next is caseating granuloma. Last is clinical, radiological, or endoscopic findings consistent with intestinal tuberculosis in an individual who had proven tuberculosis at some other sites, example lungs or lymph nodes. So this is the latest in recent papers. Now, what do you differentiate tuberculosis from? The differential diagnosis of a particular individual, where we are making keeping a differential of tuberculosis, would depend on the location of likely disease. So the differential diagnosis would be different for esophagus, stomach, pancreas, lymph node, peritoneum, or the bowel, the left side or the right side. But predominantly, we are concerned about malignancy, lymphoma. In right bowel, we would be concerned about amoeboma, bowel malignancy, again adenocarcinoma or lymphoma. IBD Crohn's, as Sir had already mentioned, is a perennial problem for us. Is it tuberculosis, is it Crohn's, and some other malabsorption syndromes. This is a table which I had taken from Dr. Poo's paper, 1998, where he has talked about potential diagnosis based on the location as well as the pathology. So intestinal lesions, ulcerative would present more like diarrhea and malabsorption. So the differential would be celiac disease, tropical screw, immunoproliferative small intestine disease, giardia, etc. For strictures, Crohn's and malignancy. For strictures, yes, adenocarcinoma and lymphoma are a differential. In individuals who has a history of elderly or significant CAD, ischemia would also be a differential here. For hypertrophic kind of a disease, carcinoma cecum, appendicular lump, amoeboma, actinomycosis, etc., perforations, typhoid is always there. For peritoneal disease, ascites and tubercles, if it is plain ascites, you need to think of even a low protein ascites, etc., etc. I'll be talking on that later on. So why were we so so most of my talk is on diagnosis. Sir also talked only on diagnosis, how to differentiate this from that. Why is so difficult for tuberculosis in abdomen? The problem is uh, abdominal tuberculosis, like most extrapulmonary tuberculosis, is possibacillary and sometimes difficult to access tissue. If the involvement is only in mid-jejunum, and if you want a tissue, you will have to have enteroscopy to get that tissue. While for a pulmonary tuberculosis, sputum examination, which you can ask repeatedly, would be available. So yes, possibacillary disease with difficult access to tissue is a problem. So how do we go about diagnosing tuberculosis? We start with, uh, as like as in any other situation, supportive evidence after a clinical history examination, supportive evidence would be sought for, and this becomes very important if in our differentials diseases such as irritable bowel syndrome are still there. So if we are uh, seeing a patient in the clinics with abdominal pain, alternating constipation, diarrhea, but we're not very sure whether the disease is there or not, organic disease is there or not, I would be interested in looking at CRP, anemia, some evidence of malabsorption. Young male with a normal CRP, no anemia, uh, chances of ending up with diagnosing tuberculosis in him would be low. So that is the importance of supportive diagnosis. Uh, I'll have there is we should always be looking for evidence of COX elsewhere, even in clinically or on investigations. And I'll have a slide on mantle. So again, it is something which is very common. It only tells us that talks about latent tuberculosis. In this setting, I'll be putting forward only 2 points here. It is neither sensitive nor specific to make a diagnosis. In small children, positive MAN2 strongly indicates active inflammation, active infection. And for our practice, I'll say if it is a strongly positive MANTO, the chances of this patient harboring an active disease would be slightly more. Chest X-ray. Active or healed lesion on chest X-ray can be found in 15 to 25% of patients who are finally diagnosed as abdominal tuberculosis. Always get a chest X-ray as one of your initial investigations if you are diagnosed, if you are investigating individual for abdominal tuberculosis seriously. Now, let's go definitive. Uh, Microbiological evidence. This is the gold standard for diagnosing tuberculosis. Unfortunately, in abdominal tuberculosis, we don't end up finding this. But let's talk about this first. So AFB stain, AFB culture, and put MTB, rifampicin ultra assay. These are the things I'll be comparing. So these are the diagrams which I have taken from Microbiology Journal published, where they have uh, uh, on this first graph plotted compared the limit of detection of the smallest numbers of bacteria if present, if there is some consideration of MDR disease. AFB stain is readily available within few minutes to hours, but it requires a lot of time. Large number of bacteria and usually disease. Now for abdomen, which we know is not a multibacillary disease, the positivity rate for AFB for bowel lesions as well as for peritoneum is abysmal in the range of 2 to 3% only. The culture positivity rate is around 20-30% for both peritoneal as well as for peritoneal disease is around 20-30%, while for bowel lesions it is less than this. Now here comes the importance of these new tests. Expert MTB, RIF, ultra assay can pick up bacteria in the range of 10 to 20 per ml, and the results would be available within hours. On top of that, it would give you some idea of resistance because it can pick up rifampicin resistance. So if my patient of bowel, we can think of, or we usually find in our day-to-day practice. Now, this was about limit of detection and time to results. There is another angle to it. What is the sensitivity and specificity of the test? Well, as you are aware, specificity is maximum for culture. It is considered the gold standard. The gene experts rate high on this parameter also, and is very close to this. What is the principle of this gene expert MTB RIF ultra assay? It is a semi-quantitative hemi-nested PCR. Don't ask me anything more than this. I'm not the right person on this. Microbiologist would be the right go-to person on this. But what I'm aware of is that it is a standard care for WHO as well as Indian TB eradication programs now. It has a wider availability. It is available in each district hospital now. It is recommended as routine on sputum and lymph node samples, but its status on abdominal tuberculosis is not standard of care. Why is it so? So, because the data on abdominal tuberculosis is not very encouraging. This is a meta-analysis published this year, where expert MTB RF Ultra was all these studies done were evaluated. There were around 13 studies. They talked on both peritoneal and intestinal lesions. Now, whenever you compare a new test, you always have to compare it to the gold standard. And the gold standard here is the culture. But the positivity of culture is only around 25 to 30% for peritoneal disease. So it was compared both with the culture as well as the composite reference standard, which I talked about earlier, or the clinical endpoint. As far as sensitivity goes, the sensitivity in peritoneal disease was 30%. We hardly use it for peritoneal disease, by the way. However, for intestinal disease, the sensitivity is again around 23%. In intestinal disease, in this paper, the test could not be compared with culture because only three of those 13 studies talked about culture of intestinal tissue, and the data was patchy. So take home on from this is, if used and positive, the tests give you a reliable diagnosis of tuberculosis. However, the sensitivity of even this test is 23 to 30%. When compared to culture, the turnaround time would be the test would be available within a day. So it is a useful test. Radiology forms the so after supportive investigations, radiology forms the backbone of investigations in evaluating abdomen for mycobacteria for tuberculosis. And things we do: X-ray, ultrasound, barium not so commonly done now. I'll say not done routinely now, and CT abdomen. Ultrasound is a widely available investigation, low threshold diagnostic procedure. It gives you valuable information, especially for peritoneal disease, can pick up lymph nodes, organomegaly, and occasionally can also talk on ileocecal colonic involvement. It is also very useful to pick up samples, cytofluid aspiration or FNAC from lymph nodes. BM studies, it used to be the gold standard for evaluating, non-invasively evaluating the small bowel with a good diagnostic test, highly sensitive tuberculosis with multiple strictures and distended cecum, etc. Will still, I do not use this test any longer in my clinical practice. Others will can talk about what their experience of using barium now is in 2020. But yes, you can have these old diagrams in your exams. You should be aware of these things. Gooseneck deformity. There are many other such terms. Computed tomography, it is the most common finding on CT, which are highly sensitive to tuberculosis, are high density ascites, lymphadenopathy, bowel wall thickening, and irregular soft tissue densities in a mental area. If you have a combination of most of these, it is most likely tuberculosis, because many other differentials would not stand when you have usually involvement of many other things. So CT has become the backbone of evaluating these patients, and I like to uh, say that if we are evaluating bowel, we should be asking for CT enterography from a competent center. It takes it improves our evaluation of bowel greatly if properly negative oral contrast, either polyethylene glycol or mannitol in large volumes in short duration can be given. It is ideal test to non-invisively image bowel and surrounding area now. So unlike barium, it would also give you uh, information on mesentery. It would give you information on peritoneum, lymph nodes, uh, large organs. So a properly done CT enterography or MR enterography is very useful. Lymph nodes in lesser omentum, mesentery, peripancreatic, and upper periaortic, while lower periaortic nodes are commonly seen in lymphoma. What is very important is this, the feature of lymphadenopathy, peripheral lymph enhancement with a multilocular appearance. When you compare these three commonly used modalities for their ease, ultrasound definitely scores way ahead. For peritoneal disease as well as lymph nodal disease, bowel assessment is best area, but CT enterography is not behind. I'll say is equal. Solid organs, both by ultrasound and CT. Assessment of bone masses, ultrasound and CT. Guidance of procedures, ultrasound and CT. That is the reason of barium is going into disuse. So ultrasound, if you want further information, CT. For endoscopy, colonoscopy predominantly, because most of these diseases are, we want to look at colon and the right side of bowel. Occasionally, we might need um, to look at esophagus, stomach, or duodenum. And the jejunum or mid ileum or distal ileum has to be evaluated, then you would need an enteroscopy. So what do you usually find in colonoscopy? This would again be a repetition in later slides. It would be hyperemic nodular friable mucosa, irregular ulcers, sharply defined margins, and undermined edges. Might find pseudopolyps, and it is important to take adequate biopsies from these ulcer edges. Biopsy may not granuloma in many cases, as the lesions are submucosal. So granuloma is only seen in 8 to 48% of colonic biopsies. when taken from ulcerated areas, and of these, only 1/3 would have caseation. So caseating granuloma would be even less commonly found. AFB-CN is variable, but is not more than 3%. Culture positivity is around 30 to 40%. I'll say endoscopic biopsy specimens must be subjected to a gene expert for detection of AFB. Another way to take out some tissue if needed is FNAC from lymph nodes. You can have not necessarily only abdominal lymph nodes. Any lymph node, if enlarged, can be of use. If peripheral nodes are available, a biopsy from peripheral axillary or a cervical node may be welcome. In a mediastinal lymph nodes can be sampled from EUS. Periportal, peripancreatic nodes can be sampled from EUS. Periaortic nodes can be sampled. So this is commonly being done these days, node and a EUS sampling of the node being done. This gives an important expert analysis. Ascites. Now, if so what all evaluation would be needed in case where the predominant involvement is peritoneal? The common differential is peritoneal carcinomatosis. Why I said so? Because I'll be talking here on a low sag ascites. I'll not be talking mixed ascites here. So in a low sag ascites, in clinical practice, the common differentiation would be needed from peritoneal carcinomatosis. So what is same? Why is the confusion? Well, both of the diagnoses are pretty common to start with. Present as painful ascites, low sag ascites with high protein, and in imaging you end up finding nodules with enhancement of peritoneum. So sometimes it is difficult to, especially in individuals who are 40ish or more, this might be difficult to differentiate from peritoneal carcinomatosis, and you would not like to miss this diagnosis. What are the clues which can help you? Well, the presence of fever and constitutional signs may point towards tuberculosis. Presence of primary malignancy or presence of TB elsewhere may point to these diagnoses. However, I'll say that in present era, this does not hold true. You can have a CA breast patient on chemotherapy developing ascites, which would be tubercular, and you can have a patient who has tuberculosis somewhere developing ascites, which might turn out to be CA ovary. So it has to be taken in proper clinical perspective. So, are there any clues? I said on imaging they would both have some nodular enhancement, etc., etc. But yes, there might be some clues. Tubercular ascites, the thickening of the parietal peritoneum would be a smooth thickening. There would be soft tissue infiltration of the mesentery, smudged and dirty appearance of omentum, while of maybe caked appearance of omentum. So these are the two images. The left side image, left top, shows a very smooth, thin, enhancing peritoneum. And on this lower is showing quite a hyperemia in the mesentery. While the right to make a definite diagnosis. Ascitic fluid analysis. This is what you usually get in tuberculosis, TLC from 150 to 4,000 cells per cc. A differential count predominantly lymphocytes. A low sag is a most important differential, and yes, you start talking about TB versus peritoneal carcinomatosis and only low sag ascites. Here we have already talked about ZN occasionally positive. I talked about G word. There would be so I'll not be talking about again. 35%, and you need to have cytology for malignant cell for this to be tubercular ascites. Now, let us talk about ADA. This is now in existence for around 15 years. It is enzyme. It is an enzyme involved in purine metabolism, and is a marker of proliferation and differentiation of T lymphocytes predominantly. So it is an indirect marker. Yeah. So it is being used in increased levels in CSF, pleural, and ascitic fluid has been taken as marker for tuberculosis. There are various cutoffs in each fluid. In ascites, the sensitivity and specificity of this test would depends on prevalence. So the values would be different in say US and Europe versus what they are in India. There would be lower negative predictive value in immunodeficiency. So as I said, this is a marker of T cell proliferation and differentiation. So in individuals who have cirrhosis, HIV, chemotherapy, etc., the ADA levels might be false negative. And you cannot predict in a cirrhotic patient with an ADA of 18, you cannot say, no, this is not tuberculosis because the ADA is low. The cutoff value of more than 130 international units per liter in immunocompetent uh, uh, individuals in high endemic area has been shown to have high sensitivity and specificity. It is a good ancillary test to have. A totally negative ADA or strongly positive ADA would definitely in clinical scenarios would help you um, clinch a diagnosis of tuberculosis or refute a diagnosis of tuberculosis. Avoid on serum and ascitic fluid tumor markers. There is no role in differentiating peritoneal disease, either tuberculosis or malignancy, ovarian malignancy, etc., etc., etc. CA125 is high in tuberculosis as well, and it would start decline by fourth month of ATD. So there is no CA125, CA99, CA in blood, oblique ascitic fluid to differentiate TB from peritoneal mets. The role of these markers is in following a patient of peritoneal of malignancy in response to therapy, etc. I'll say um, it is always useful to send some ascitic fluid uh, for cytospin so that smear can be made, and on that smear malignant cells and gene export can be done if needed. The second thing is, as I've uh, described in those CT images, in case there is significant omental caking or nodule formation, it is always wiser to take USG guided biopsy, which can give you a better clue on histopathology, one way or the other, commonly malignancy. Biopsy taken from omental nodule, if negative for malignancy, everything fails, laparoscopy. You should not shy away from it in case where the diagnosis, even after these much of tests, you are not able to make a diagnosis of uh, etiology of low SAG ascites. Laparoscopy should be asked for. Thickened peritoneum with tubercles, without tubercles, fibroadhesive peritonitis, lymph node sampling. It will give you tissues, the the description. Otherwise, also, uh, it is more than 70% sensitive and specific to make a diagnosis of tuberculosis oblique malignancy. So this is an old slide. It does not include recent inclusion of gene expert, but yes, or USG guided omental biopsies. But yes, uh, where everything else fails, laparoscopy, visual diagnosis, or histology can clinch diagnosis in more than 90% of cases. And it is an important tool. Should always remember this. So if a SAG is present, what is a SAG? If it is high SAG ascites, it is uh, ascites secondary to portal hypertension. In this, if it is still SAG with high cells and lymphocyte predominant, I'll still be interested in looking at ascitic fluid ADA. You can think of starting tuberculosis if everything else is fitting. If it is low, may send TB culture, may send gene expert, or diagnostic laparoscopy. Now, let's talk about TB versus Crohn's. These are our major problems. TB versus Crohn's, predominant intestinal lesions, there's hardly any ascites, there are hardly nodes elsewhere. Why is the problem? Clinical features overlap completely. And it is difficult to differentiate on routine blood tests, imaging, endoscopic images, and even histology. So, what do we do? Well, the good point is, are there any 100% specific tests to diagnose TB versus Crohn's? For Crohn's, unfortunately, no, none. There is no single test or even a combination of tests by which you can uh, say with 100% confidence, or in other words, 100% specificity, this is Crohn's. For tuberculosis, we have AFB smear, AFB culture, gene expert, or necrotic lymph nodes on CT, or caseous necrosis. But the problem is most of our patients would not be positive on these parameters. So what do? We try to differentiate these, and I'll be taking you through this differentiation step by step. So let's first start with clinical features. There is a whole lot of influence, but yes, longer the duration, less the chance of tuberculosis. If there is an individual with a history of 5, 7, 10 years of symptoms, the chance of tuberculosis would go down. Constitutional symptoms are commonly seen in tuberculosis: fever, night sweats, but then your Crohn's patient may also have an abscess and maybe throwing fever. Lung involvement ascites definitely a feature of tuberculosis. For Crohn's disease, diarrhea, because the ulcerative lesions are commonly seen. Hematochezia, because the left-sided lesions are commonly seen. Perianal disease and extraintestinal manifestations are commonly seen. But then again, diarrhea, hematochezia, perianal disease are all also seen in tuberculosis, and we commonly see more TB than Crohn's. As far as extraintestinal manifestation goes, uveitis, spondyloarthropathy or spondyloarthritis, erythema nodosum, common extraintestinal manifestations which you associate with Crohn's are all seen with tuberculosis as well. So clinically, it is very difficult to say that this is Crohn's or tuberculosis. Now let's come to endoscopy. There are some pointers in endoscopy. In tuberculosis, there is commonly more right-sided involvement, while in Crohn's disease, left-sided involvement is more commonly seen. If you are seeing longitudinal ulcers, this is less likely to be tuberculosis. Cobblestoning, mucosal bridge is not commonly seen with Crohn's disease. So I told you 2 things, but even after that, seeing these images, yes, this looks more like Crohn's. Why did I say though? There are some longitudinal ulcers. There is staining here, and fairly large ulcers. So the top pictures were Crohn's. While the lower two, this is the transverse ulcer causing partial stricture. Partial stricture was in this Crohn's list, but yes, this turns out to be tuberculosis. And yes, ileal wall involvement with some gaping ileal wall, this was tuberculosis. So based on simple endoscopic findings, it's still difficult to differentiate the 2 things. Sorry, I missed this. So just well, clinical differentiation radiology, the extent of lesion would so just a minute again, sorry. So on this let's look at it again. So this is comb sign, and the comb sign is because of the vascularity or mesenteric hypervascularity. So this is not commonly seen in tuberculosis. So in this image, comb sign with long segment involvement points possibly tuberculosis more likely. While this necrotic node and this ileocecal involvement. Another important thing in radiology which I'd like to point out is, I've already said this before, 25% would have concomitant chest X-ray findings, and there is data from AIIMS, and they have analyzed it and said, sorry, that, when they did CT chest for all such patients who had the dilemma of tuberculosis versus Crohn's, they get additional 24% who had findings on CT chest, tilting the diagnosis toward tuberculosis. So TB versus Crohn's, not enough direction from abdomen, do get chest. Histology, yeah, granulomas. Then granulomas are the problem. You have granulomas, necrosis is there, it is good. You have clinched the diagnosis. Out of that, you just need to differentiate from TB versus Crohn's. Crohn's granuloma would be slightly smaller, they would be discrete, ill-defined scar, not definitive. There are others on histology which point towards one way or the other. Disproportionate submucosal inflammation in the tuberculosis seen, and yes, granulomas in lymph nodes can be seen in both TB and Crohn's, but in tuberculosis you can have granulomas at places where bowel involvement was not there. which is not seen in Crohn's disease. In Crohn's disease, you can have granuloma in lymph nodes, but it would be in nodes with nearby bowel involvement. In Crohn's, you would have something else. It would be inflammation in bowel distant from granuloma. So these are soft pointers which might point you towards one way or the other. Microbiology, I've already discussed it. If positive, it is diagnostic for tuberculosis, but poor sensitivity. So the harsh reality, at least in India, TB versus 2017 data from Korea, they had 2 years data, and they had reviewed it. They had compared it with the previous in-house data. So what they found was that 48% of TB patients were confirmed on presumptive ATT. That is, their patients were labeled as tuberculosis only because they were responsive to TB. While 18% of their Crohn's disease patients received prior ATT. They, over last 5 years, have found a trend that they now more confidently diagnose Crohn's disease. So, misdiagnosis of Crohn's as TB has decreased, but this has led to misdiagnosis of tuberculosis as Crohn's. They were more likely. There's data from AIMS also, in which around 350 Crohn's patients on their follow-up, around 38% of the patients, Crohn's patients, has received at least 3 months of prior ATT. So in Asia, in East, where tuberculosis is rampant, making a diagnosis 6 months, around 35% of those patients, it was not 360 Crohn's patients, it was 35% of their 350 Crohn's patients who had received ATT. So the number was around 120 only. So 120 Crohn's patients receiving ATT, and tuberculosis 150 patients received ATT. So at 3 to 6 months, even 35% of Crohn's patients had shown response, clinical response. Clinically, they had improved, while around 90% of tuberculosis patients had clinically improved. When those patients who had improved were followed up for 1 year, around 80% of patients who were ultimately diagnosed as Crohn's had relapsed. While for tuberculosis, all 100% patients who had shown response sustained response. At colonoscopy at 6 months, in patients who had response, only 5% had endoscopic response when the underlying diagnosis was Crohn's disease. While for tuberculosis, it was 100% endoscopic response. So this means in Crohn's disease also you can have a clinical response with ATT, but it would not be sustained and it would not be an endoscopic response. While for tuberculosis, it would be a sustained endoscopic response. You may ask why this 90% figure is there if we are talking about tuberculosis and response. This was a clinical response. Now there are there is situation where clinically patient does not improve, and it is usually because of complications which have developed. The commonest being development of a stricture requiring surgery, etc. So again, this flow chart is from that same AIMS paper, where they have talked about how to go about a therapeutic trial of ATT in when you are concerned about Crohn's disease as a differential. So if there is a diagnostic fusion between Crohn's and intestinal tuberculosis, and you are starting on ATT, look at clinical response at 2 to 3 months. If there is clinical improvement, continue your ATT for 6 months and look at endoscopic remission. So if clinical and endoscopic improvement, it was intestinal tuberculosis. If there was symptom persistent and active disease on endoscopy, it is Crohn's disease. If the clinical improvement is there, but there is still active disease on endoscopy, it is Crohn's disease. So even if after your fibrotic stricture, continue it as tuberculosis, the non-response is not because of this being Crohn's disease, it is because of this being development of fibrotic stricture. In case of an active disease, consider possibility of Crohn's disease. Again, this paper published in World Journal Gastroenterology 2009 by AIMS Group, KDS et al. is a good read. There are a few other papers from Liu et al. From Korea, and which talk about interstitial tuberculosis, and Crohn's disease. Now, 3 slides on treatment. How do you, so what is the medical regimen for, now 3 slides on treatment. How do you, so what is the medical regimen for treating tuberculosis? This is the Index TB guidelines for extrapulmonary tuberculosis 2007.